Greetings, my brothers and sisters. Sending gratitude to all of you who are joining in today to accompany us down the rabbit hole of self-exploration through plant medicines. My name is Ryan Sprague, and I'm here to tell you that your frequency is now set and tuned to explore psychedelic medicines and the impact they've made among the countless psychonauts exploring the last true frontier. Buy a ticket and take the ride with me as we get true first-hand accounts of the experiences, benefits, risks, and transformations taking place within the ever-expanding world of psychedelic medicines on This One Time on Psychedelics. When it comes to the idea of plant medicines and psychedelics as medicines, it is becoming clearer and clearer that one of the most profound ways in which they can operate is in the realm of mental health, and moreover, being able to have the ability to create personalized treatments for neuropsychiatric disorders, aka disorders that include both neurology and psychiatry, such as seizures, attention deficit disorders, and cognitive deficit disorders. I truly feel that these medicines can assist in the human experience in such profound ways, and that we have only begun to scratch the surface with regards to the potential residing within these medicines to assist in the well-being of our physical, mental, emotional, and spiritual bodies. Stopping by to share his time, wisdom, and experience with us today is a gentleman who is on the cutting edge of viewing psychedelics as potential medicines for disorders like the ones mentioned above and more. He obtained his MD and PhD in cell and molecular biology at Lund University in Sweden, and has spent the last 2 decades holding senior clinical development roles in the pharmaceutical industry in Denmark, Sweden, the UK, and the USA, and has worked on 5 late-phase clinical development programs for depression indications, 3 of which have resulted in regulatory approvals for major depressive disorder. In addition, he now serves as the Chief Clinical Development Officer at Brain Health, where he ensures that the strategies being used are aligned with the promises of the compounds in development. And if all of that wasn't enough, he is also a leading voice behind the movement to look into psychedelics for precision psychiatry, to allow patients to stop going from medication to medication and instead be able to have an individualized plan from which to find relief from. This episode is one that I have been beyond excited to record, as I truly feel this is a topic that needs to be discussed and portrayed in the mainstream, as within the realm of plant medicines and psychedelics alike, there is still so much to understand to be able to offer those who are interested in exploring these medicines a clearer approach to doing so. So, with all of that foundation being laid, please give me a big hand in welcoming my man Hans Eriksson to the show. Hans, pleasure to have you here.
Thank you so much. It's great to be here.
Yeah, I was so excited as I was talking to you before we hit record. When originally I think your media team reached out to me about having you on the show, I was blown away at how much you have done within the realm of just psychiatry as a whole, let alone with plant medicines and psychedelics. And I'm curious for you, give us a little background on how you got into the fields you're in now, both psychology and then moving into looking at, psychedelics and plant medicines as a potential treatment for this realm.
Okay, I'll be happy to do that. So, as you have said, I'm a psychiatrist by training, and I started out my career as a clinical psychiatrist in an academic setting in Sweden. I thoroughly enjoyed working in the clinical setting, and I've had a couple of attempts to do it over the years, even since I joined the pharma industry in about 2000. The reason I went to the industry was I wanted to be able to bring new treatment approaches to the patients that I used to be seeing. I started out working with more traditional drug development projects with small molecules and working on SSRIs and on the typical antipsychotics that were brought to the market for the treatment of depression. And I think those achievements were important, but over time I saw that there were things happening in the psychiatric space, and actually 2 different themes emerged. One was the emergence of the broad group of, let's call them psychedelic compounds, both the traditional psychedelics, the more serotonergic agonists, but also the dissociative compounds, more NMDA receptor modulators. And these compounds came with tremendous promise, with signs of substantial benefit, high response rates, early onset of effect, and also in some instances, the potential to provide long-lasting benefits also after the medication has been given. So that was one of the aspects that interested me and actually brought me for the first time in contact with psychedelics, where I was working with one of the psychedelic compounds that is currently in clinical development. The other thing that happened was that at long last, my complaints of psychiatry as being a one-size-fits-all discipline sometimes seem to get a response, because, as you know, traditionally in psychiatry, a patient comes to you and you make a diagnosis as well as you can, and then based on that, you're selecting a medicine based on what you think would be most appropriate. But to be quite honest, there are not really strong guidelines about which antidepressant or which antipsychotic you should select. So it has to a large extent become a trial and error approach. And we have seen in large clinical trials, for instance, the landmark STAR-D studies that came out more than a decade ago, really showed that only a small proportion of depressed individuals get adequate improvement after the first treatment. And even after 3 treatment steps, a substantial proportion remain unsatisfied with the treatment. And to some extent, this is due to the fact that this process is followed. And the natural question is there a way to find individuals early on to determine whether they are likely or not likely to respond to the intervention? Until now, it has been very difficult. There have been lots of attempts made to look at clinical presentations of depression, for instance, but it has not been a really good guidance. And then, fortunately, the organization where I'm working right now, we are now developing not only novel medicines, but also companion diagnostics that go hand in hand with these medicines. And here the idea is to not treat everyone, because I don't think there is such a thing as a panacea in psychiatry, but rather target these medicines to persons with specific biological disturbances where they can make a tremendous importance, while not necessarily giving them to people with a low likelihood of responding. So we are also not building up false hopes for these individuals, and they could start trying something else. So I think those 2 trends have been very, very important to me. And both of them are very much alive at HMNC Brain Health, where I'm spending my working days.
That's so beautiful, because one of the things you said in that I wrote down was long lasting. And this is one of the things that I think Western medicine and the pharmaceutical industry can be great, but I do think it's missing a lot of components to it. Like you were saying, right? Like my story is, how I first got interested in the cannabis was it was the only thing that helped with anxiety. And I went to the doctor and went through every single different pharmaceutical. And it was funny because when I originally met with the doctor, he spent about 5 minutes with me before he, diagnosed me with generalized anxiety disorder, which isn't inherently, wrong or anything like that, but it is a growing trend, right? Where people are saying, yeah, they spent 5 or 10 minutes with me. They told me I had this thing. And I think one of the biggest challenges too is once you're diagnosed, you get put almost into a box, both by the doctor and also yourself too, right? Because you start looking up, like for me, it was like, oh, I have generalized anxiety disorder. Let me look up information on that. And it's really challenging. It kind of seems one-sided in a lot of different ways. And so I love that you're not only opening up this new realm, that, is definitely not for everyone, right? Not everyone will benefit from psychedelics, but there are certain people who will. And so why allow those people to not find benefit when we have these medicines available? I think like everyone, there's different strokes for different folks, but at the same time, these medicines have such promise. I mean, just what I've seen with MDMA in the phase 3 trials has just been unbelievable. And then with ketamine as well. And that's something I want to get into with you about, because I know ketamine is used pretty heavily in the realm of depression and with great results in a lot of times. And this is a medicine that I've only recently, become not interested in, but made aware of. And by aware, I don't mean necessarily I knew it existed, but, it's something that I've only recently started looking into. And so I'd love if you could break down, because I think you guys have a product that's actually based on ketamine. I don't think it's exactly ketamine, but I'd love for you to dive into that a little bit and what you found with regards to ketamine and depression, because this is a big subject. Hey, everybody. I hope you're enjoying the show. I wanted to take a quick moment to let you all know that the doors are officially open for the Conscious Cannabis Collective. And as such, this is the last week you can sign up and receive all of the bonuses we're currently including. This is the last time I will be personally onboarding those of you who sign up with a complimentary one-on-one session, and you'll have the ability to get the Grow with Cannabis course for free during this limited time. For more info on how you can take advantage of this offer, Head down to the show notes for this episode and secure your spot today, as we only have so many spots left and they are filling up quickly. Now back to the show.
Of course, and it's a very interesting area. And so if you think about ketamine, this is an old compound. It was developed by Park Davis in the US during the 60s, and it has been available as an anesthetic agent since 1970. And it has been also widely used in settings outside of hospitals, so like in disaster areas, in war zones, and it's very safe to use in even such a setting. And during the last 2 decades, there has been an increasing interest in using this medicine as a potential treatment for depression. It's thought to act by interaction with a specific receptor, the NMDA receptor, but probably also with other receptors. And the hallmark on the efficacy side of ketamine and other similar compounds has been a very rapid onset of effect and also quite a substantial benefit. So it has been really a true novelty in the space of psychiatry, where most other medicines traditionally have been based on modulating monoamines like serotonin, norepinephrine, dopamine. Mm-hmm. It came to a market that was in dire need of something new to help these patients who don't respond well enough to the traditional interventions. So that was the upside. I think the flip side of ketamine to some extent has been that it is in many cases associated with dissociative effects that are perhaps something you could put under a bigger psychedelic umbrella, even though they are not properly the traditional psychedelic effects. And these experiences are for some patients unpleasant, for others they are not. But for the only ketamine-based medication, which is a nasal spray of the S-enantiomer that has been approved, this has led regulators to say that because of these dissociative effects and also because of the blood pressure increase that can be seen, it's necessary to give this medicine under adequate medical supervision. And there's nothing wrong in that, of course, but it has really become an obstacle to a greater uptake of this treatment modality, because patients need to come into the physician's office a couple of days per week. They need to take the medicine, and then they need to be under supervision for a couple of hours. And the staff at the office or in the hospital need to be available. So there have been some practical problems around it as well. And there's also been a huge debate about whether the dissociative experience is necessary for a clinical benefit. And I have a strong opinion here, and I'll come back to that later. But I would just like to say that I don't think we should lump all the compounds within this psychedelic space in one bucket, because their mechanisms of actions are indeed different. And even if you look at closely related psychedelic compounds, they really do induce different qualities of psychological experience. But our thinking here has been, what if it would be possible to provide the benefit of ketamine without the dissociative experience, because that could then open up for a much more practical use of the compound. So our thinking here has been to not change the medicines. We are still actually using the traditional ketamine, which is a racemic formulation, meaning that it consists of 2 different types of molecules, which essentially are mirror images of each other. So we're using the racemic ketamine, but instead of giving it as a nasal spray or as an intravenous infusion, which has been the normal ways to give it, we are working with an oral formulation, and it's an oral prolonged release formulation that has been developed by our co-development partner, Develco, which is a Swiss company. They developed a prolonged release formulation whereby the concentration of ketamine gradually increases over several hours. And also because the medicine is taken orally, all medicine that is taken up by the body goes through the liver, and the liver is really good at start converting ketamine to the metabolites, some of which are also active. We believe that these 2 features, avoiding the initial rapid peak and also the high level of what is called first-pass metabolism by the liver, contribute to a really good tolerability of the compound. So the formulation was shown in early clinical studies and also in a study in a pain condition to be associated with very little dissociation. So there was a sign that this could actually be a good treatment for depression from a tolerability perspective. But of course, there's no point in giving it unless it works.
Yes.
So the proof is in the pudding, so to speak. So that's what we have embarked on demonstrating now. And a little more than a month ago, we could communicate the first results from a small proof of concept study conducted at University of Zurich in Switzerland. This was a study in depressed patients who fulfilled criteria for treatment-resistant depression. So these were patients who had been struggling quite hard to overcome their depression. And the medicine was given as an add-on treatment on top of a standard antidepressant. It was given daily for 2 weeks, morning and evening. And the patients were hospitalized, so were under very good medical supervision. The original idea was that the study should have been larger, but during the COVID, there were problems to get patients recruited with the speed that we had anticipated, or that had been anticipated. So the study was terminated a bit early. So the total sample size was 27 patients who were in 1 of 3 different treatments, placebo, or 1 or 2 doses of the prolonged release ketamine. The interesting thing that was in this small study, there was a substantial numerical improvement in the depression severity scores for the patients who were on the high dose of ketamine, but not on the low dose compared to placebo. And the magnitude of that improvement was clinically clearly meaningful if you're using, looking at the standard rating scales that we are using. It fell just short of meeting statistical significance, but as I mentioned, the study was small. So here we actually, for the first time with our compound, see data demonstrating that, yes, there is a strong signal of antidepressant efficacy that seems to be coming without dissociation, because the dissociation ratings using the dissociation scale were on placebo level, and there was also no blood pressure increase. So to me, it shows a strong indication that we are on the right path in finding the sweet spot when it comes to ketamine treatment, being able to benefit on the antidepressant properties of the compound without necessarily inducing the side effects that have become a sort of a practical problem, in addition to being unpleasant to some patients. So that was really a milestone for our company to achieve that. And it was a really nice work conducted by the colleagues over at University of Zurich in Switzerland.
What is up, everybody? I hope you are all enjoying the show, and I wanted to stop by real quick and share a little bit about our latest podcast sponsor, Freedom Builders. Now, Freedom Builders are a team of graphic designers, website creators, videographers, social media marketing experts, and coaches that build out your custom online business from A to Z. This is a done-for-you service, which means they do the work for you, while you get to put your focus back on what you love most, which is coaching your clients and bringing in sales. Now, as a former online fitness coach, Mike knows where your struggle points are and exactly how to help you overcome them. This is why he created Freedom Builders, so that you can scale your business while protecting your time and your energy. Now, you guys know that delegation is a business superpower, and you can activate this superpower today by scheduling a complimentary call with Mike at freedombuilders.com, so you can start building the freedom that allows you to take your business to the next level. Alex and I recently connected with Freedom Builders for our Connect with Cannabis build-out, and we could not have been happier with the results. With Mike and his team, they were able to go through an outline and create a personalized program for our experience, develop our brand identity, build and design a custom branded webpage, professionally edit our program video content, custom design all of our slide presentations, automate our email marketing sequences, create a seamless payment system for our offer, design unique infographics for our social media content, and guide us through our proven launch blueprint to generate organic leads through our social media. So if you're a coach, facilitator, or healer listening to this ad right now, and you are looking to put freedom back into your life, once again, go to freedombuilders.com and book your complimentary call today. I hope you all enjoy the rest of the show, and I'm wishing you the best day ever. You know, what I love that you're doing is, for some people, yes, the dissociative effects are, I wouldn't say that's maybe enjoyable, pleasurable, or not an outstanding thing that's going to keep them from it. But from a lot of people, it is going to be something that prevents them from wanting to interact with it, right? They like their normal lease on reality. They don't want to shift that. And I understand that. And so it's amazing that you're being able to not only administer ketamine in that type of way, but also be able to look into it as specifically being able to take away the dissociative effects along with decreasing the blood pressure increase and still being able to get people these results. And one of the things that I'm curious on is, and you mentioned earlier, the long-lasting effects. And we hear this with MDMA, with ketamine, et cetera, that they can give long-lasting effects. With MDMA, it's PTSD. With ketamine, it's depression. What makes specifically ketamine be able to have this long-lasting effect as opposed to typical pharmaceuticals? Because I think that's one of the things that I get most curious on, is because I've had experiences with these medicines and I've felt the effects of it, but being able to have the understanding and the intellectual component behind it, I think is really useful for the listeners as well.
Yeah. So I think there may be a difference between the NMDA modulators and the more traditional psychedelics in this respect, because I think for more traditional psychedelics like MDMA, psilocybin, perhaps LSD, there seems to be a potential to have a long-lasting effect with a single or a couple of administrations. For ketamine, if we, for instance, look at this nasal spray I was referring to, it's been possible to demonstrate, yes, there is early onset of effect, but in order to maintain the benefit, you need to continue administering the medicine, albeit at longer time intervals. I think if I were to guess, because right now we only have short-term data from our compound, I think there will probably be a need to have some sort of less frequent maintenance therapy over time, but we don't know that yet. So we now have this small study with short-term data. We are just, as we speak, recruiting patients into a larger phase 2 study that has started in Europe. And we will once again administer our prolonged release ketamine formulation, but this will be in an outpatient setting to patients with treatment-resistant depression in 3 countries in Europe. And that study, as I mentioned, is just about to start. That will also be a short-term study. And the following steps will be to explore how do we achieve the best maintenance of effect. So I think the jury is still out a bit on this, but I think probably there will be some need for maintenance treatment.
Yeah, that's amazing. You know, it's so cool because I really think about this a lot, that although there's so much incredible science and things coming out and findings coming out with regards to the entire psychedelic realm, we're still just scratching the surface, right? There's so much that is just opening up. And I'm curious for you, you know, when I'm working as an integration coach for different people that have gone through psychedelic experiences, and I lump ketamine into this just for sake of conversation, but, you know, with these experiences people have, there's always ones that catch me a little off guard, not in terms of like, I didn't expect that would happen, but more so like very profound, right? Someone who's had their life shifted or things like that. Have you come across anyone in your work that has had a profound experience like that, maybe even yourself, who knows, that you could speak to give the listeners a little bit of information with regards to what results you have seen firsthand from any medicine, whether it's ketamine, MDMA, et cetera? So,
I mean, we have heard comments from some of the patients in this Swiss study. They have expressed profound satisfaction with the improvement. So there I have it as not directly firsthand, because but that is comments that the patients have made. But prior to going to HMC Brain Health, I was working with the development program for psilocybin. And in that context, I came across patients who had very profound and positively life-changing experiences. So I'm personally a very strong believer in this approach. But I also think that we as an industry have a very strong responsibility, so we are able to provide these interventions in a safe and responsible way. I think the major players in the field who are developing their different versions of psychedelics generally are doing that. They understand that for this to become successful, there needs to be a very careful way in which the medicine is administered. I think for the traditional psychedelics, it makes eminent sense to package them in the context of either a supportive psychotherapy to make sure that the medicine can be administered safely, but perhaps even more importantly, more elaborate therapy that can prepare patients for the sessions and also can take care of the experiences afterwards in integration sessions. The patients I met who had that experience from other psychedelic compounds, some of them have really convinced me that this is a major game changer in how we treat patients in psychiatry. So I used to say that we are right now on the threshold to the second revolution in psychopharmacology. The first one happened during the 50s, where all the first versions of our modern medicines that are currently in use came into clinical practice, like the first antipsychotics, the first modern antidepressants, and also the first anxiolytic compounds. And then not much has happened over 60 years or more. But now all of a sudden, sponsor after sponsor, academic group after academic group is exploring the potential of these compounds that for some period was actually held back by regulations, but where there is now quite a different openness to actually find the best treatment for patients.
I love that, and it's so cool because what I found is specifically with one of the things you were talking about in there, set and setting, right? We hear about this a lot, right? One of the things that I've realized is that a lot of people don't really know what the pharmaceutical industry type set and setting is, right? And so I'm curious for you, like when you guys are creating a set and setting, aka having people in under medical supervision when they're doing ketamine or these kind of things, what are some of the main things you're ensuring these people either have or they have access to be able to foster a really positive experience with these medicines? Because I imagine there are certain controls, right, with every study there are, and certain things that you want to make sure. Because one of the things that I've thought about a lot, not so much with ketamine, but with traditional psychedelics like psilocybin or LSD specifically, like those two, or anything, ayahuasca, those kind of really hallucinogenic ones, is that a typical hospital setting, right, would probably not be the best set and setting for something like psilocybin, right? Because you have machines in there, you have that really clean environment type thing, that sterile environment. So I'm curious for you, it might be different for ketamine, but what are some of the things that you guys really take footing on to be able to have that positive set and setting to allow patients to experience these medicines within?
Yeah. I mean, first of all, I agree with you that especially for the traditional psychedelics, the environment where the medicine is administered is of tremendous importance. And you can see that also when you look at the different programs that are ongoing. There is quite an emphasis on how you craft the environment for the individual. And when it comes to the supervision, I think there are two types of supervision that are necessary or that are considered. The first one is more the medical safety. And that goes for all the compounds in this category, also for ketamine. You need to make sure that the medicine can be safely administered. So we can see for the nasal spray we spoke about, you need to be under supervision so you can make sure that if there is any really bothering dissociative psychosis-like experience, that it can be managed clinically. And the same goes with all the other psychedelics. And then we have this matter of debate that pops up at every Congress. I just came back from the American Psychiatric Association in New Orleans, and the debate was there as well, to what extent the experience is necessary. I'm personally not convinced that the experience is necessary for ketamine. It may be beneficial, but I don't think it's necessary. While for the traditional psychedelics, I think there is a reasonable likelihood that you have a huge impact also from the experience. And there, I think the medical or clinical support perhaps also need to stretch a bit further than just making sure that everything is safe, but also trying to help the individual to cope with the experience and use it in the best possible way. So I think there are slightly different approaches. So if our vision with the oral ketamine approach with good efficacy, essentially without dissociative side effects, will play out, my expectation would be that the need for the more psychotherapeutic wraparound, or what you would like to call it, will be less than if you are using, let's say, high doses of psilocybin or LSD to achieve that specific experience.
Yeah.
So once again, it points to how diverse this field is, and so it's not just a question about a lot of compounds and medicines with similar characteristics. They're actually quite different between themselves.
Yeah, I mean, that's exactly what I've experienced in my own life with regards to ketamine versus something like psilocybin, right? Ketamine, I don't exactly need to take the preparation and set and setting that I do with psilocybin. It's different, right? Like I'm still going to want to make sure I'm in a safe place. I'm going to make sure there's no, loud stimulus around, things like that. Give me space to be able to actually go into the experience. But with something like psilocybin, I have to make sure like, okay, if I'm going to be doing this with anyone else, I need to make sure these people understand both the benefits and potential risks of this medicine. I want to make sure that they understand minimum effective dosing, so they're not trying to take more than they actually need. Because I think that's another big thing within the realm of psychedelics right now. obviously not in the professional psychedelic industry because you guys are actually making sure of all these things and practicing minimum effective dosing and titrating doses. But this is something I see a lot, which is another one of the main reasons I made the show, is that people are starting to think psychedelics are the cool thing to do, And whenever you have something that's demonized for so long and then all of a sudden rises in popularity very quickly, which is what's happening in psychedelics right now, I think we risk that potential interplay of people thinking, oh, the cool thing to do, let's get a notch in the belt. One of the things I hear, I'm in a lot of different coaching circles and spiritual communities, and it's almost like people are like, getting into a pissing contest with how much they've done ayahuasca or how much they've done psilocybin, where it's like, I've done 47 ayahuasca ceremonies. And, my first question is, well, what have you gotten from them? What is the reason you're going back and searching so much? Because I don't think it's inherently bad that people do them so often, but it's like, what's your reason? If you're training to be a shaman, for instance, okay, that makes a little bit of sense, right? But if people aren't integrating, then they're really using substances. They're not using medicines. And I don't give a judgment on how people use them. But what I always say is that if you're looking to connect with these substances as medicines, as teachers, then you must integrate, right? Integration is not an optional thing. That's where the real work begins, I feel, right? Because you're taking this PEAK experience that you experienced while on the medicine, and then you're actually asking yourself, how do I make meaning out of this? What meaning do I make out of it? And how do I apply it to my everyday life? Like what thread am I going to follow? What breadcrumb trail am I going to follow to get out of that? And I think one of the biggest things that me being in the cannabis world, I'm so excited is coming to fruition is genetic testing, right? That can, in cannabis's case, map out your endocannabinoid system. And when I was doing research on you, I was diving into a little bit of this realm that you do, right? That you're doing these genetic testings as well. And I'd love if we could dive into that a little bit and just talk about really what they are and what got you into, I can imagine the answer is, well, you're a scientist, so you want to be able to actually see actual correlations between these things. But, what have been your findings with regards to testing people genetically for whether or not these medicines could potentially be beneficial for them?
Yeah. So we have two other medicines in clinical development at HMC Brain Health. And those medicines both regulate the human stress response system. So the human brain needs to be able to direct the production of the stress hormone cortisol from the adrenals. So the brain sends signal to the adrenals to tell them to produce cortisol, which is the human stress response. And these signals are hormonal, a couple of different steps of hormones that regulate the system. Two important hormones here are vasopressin and corticotropin releasing hormone, or CRH. And both of these have the potential to increase the activity of the stress hormone system, which is a physiological and normal reaction when we as humans are exposed to stress. Interestingly, it has been known for several decades, not the least based on research by one of our co-founders, Professor Florian Holzbauer from the Max Planck Institute in Munich, that in a substantial fraction of depressed individuals, this stress system is hyperactive. And above all, it's hyperactive in a way that cannot be calmed down by normal feedback inhibition mechanisms. It's about a third of depressed individuals. So there's for long been an idea that if you could find tools that could stop the activity of these natural hormones that drive the stress system, you might find an angle into how to stop depression in these individuals. So some 10, 15 years ago, this idea was very much embraced by big pharma, and several companies had programs on this theme. So one of the compounds that we are now developing was actually in clinical development with a European pharma company called Sanofi. And they had it in clinical development for depression. They did two large studies that we call phase 2 studies, which are relatively large studies in patients, which are the last step before moving into phase 3, which is the full clinical development for registration. These two studies, one of them was positive, so it showed efficacy as an antidepressant. The other study showed a strong trend in the direction of efficacy. The company decided not to progress the development. Efficacy was just on par with that of standard antidepressants that at that time were becoming broadly available as generic medications. So the program didn't go further than that, but the compound landed in our hands. And our strong belief is that the efficacy that was shown in these earlier studies was probably not equally distributed among all individuals. We believe that the efficacy was driven by a subset of individuals who had a hyperactivity in the vasopressin system. So if you could only find these patients, we may actually have a good treatment for these guys. Fortunately, it is possible to find these guys Unfortunately, it's difficult to find them, but there's a solution to that as well. So you can conduct a physiological challenge test that is called the DEX-CRH test. You're administering two different hormonal molecules that are affecting the HPA axis. You draw lots of blood samples, and then you're measuring some parameters. And then you can determine whether an individual seems to have a hyperactive stress system or a normally functioning one.
Mm.
So the team at the Max Planck Institute in Munich did this test in a large cohort of depressed individuals. So they found approximately a third of the individuals having signs of the central hyperactivity of vasopressin. The clever thing they did after that was that they were able to map the outcome of this test to a genetic test. And that genetic test is now our companion diagnostic test. It consists of 14 different single nucleotide polymorphisms, SNPs, that depending on the configuration of these SNPs will be able to classify the individual as having a hyperactive stress system or a normal stress system. The hyperactive ones, they would be candidates for our compound. So what we are doing right now is that we are on our way to start up a phase 2 study, hopefully later this year or possibly early in 2023, with depressed individuals. And we will, in that development program, we will test, first of all, of course, we will test whether the compound works, but above all, if the compound works better in the individuals who test positively. So we will be developing the medicine and the test hand in hand, eventually actually get what corresponds to two different approvals, one for the compound and one for the test procedure.
That's incredible. I mean, as I said before, I think that's one of the biggest things still missing within the realm of psychedelics as we sit right now is it's kind of up in the air, right? Some people try them. They have traumatizing experiences. Some people try them and they're like, oh my goodness, this is the best thing ever. But what's like the mechanisms behind that, right? And I think that's what these genetic testing procedures are going to be able to illuminate. One of the things I love chatting with psychiatrists, scientists, et cetera, with is because you're in the pharma industry, right? Because you're well aware of this industry. And, I think the industry gets a lot of flack for a lot of things that, no industry is perfect. But at the end of the day, what the pharmaceutical industry has done overall, I think is really powerful. And it's leading to these new discoveries that you're doing, that MAPS is doing with MDMA, and et cetera. But what do you think some of the biggest challenges right now in the pharmaceutical industry are as of the present day?
I think one major challenge is to change the mindset in pharma in general, because all the best-selling medications that have brought in quite a lot of money to pharma companies over the years, like the SSRIs, like the Prozacs of the world, like the SNRIs, the Effexors of the world, and so on, they were all developed for broad populations. And I think in hindsight, one could say that maybe they should have been trying to explore which patients that would benefit the most from the treatments. At the same time, it was very difficult at that era to do it. And clinical characteristics are not really good indicators of which patient will respond, who will not respond. I think now when we are starting to see that it's indeed possible to use a similar approach in psychiatry as our colleagues in oncology have been using for more than a decade, namely developing medicines together with tests that identify the individuals that are more likely to respond. I think it will lead to a revolution within psychiatry. And I think there are two aspects to it. First of all, the ones who will be selected by the test will probably have quite good benefit of the treatment. The ones who will be deselected by the test, they will not have to spend 6 to 8 weeks hoping for a cure that may never come. They may seek an alternative intervention earlier on. My vision is that if you look at a couple of decades downstream, I think there will be more and more medications that come with companion diagnostics. So the clinician can make an educated decision by testing the patients early on to say, it's more likely that treatment B is the one that is going to help you than treatment C. And thereby we can really lift the quality of the psychiatric interventions that for too long, unfortunately, has been like flying in a fog.
Yes. It's the same within the cannabis industry, because people would come in, they'd say, oh, my friend recommended such and such a strain to me. They would try it. They would hate it, or maybe they love it, but they don't know why they loved it. And I was recently talking to a gentleman named Len May. He is essentially doing It's not exactly endocannabinoid system mapping, but it's same, but different, right? It's a very similar genetic testing procedure that allows people to understand what constituents within the cannabis plant work well for them. So then they realize, or they are able to understand whether or not they need an isolate, like just CBD, for instance, or if they need a more full spectrum approach. And I think that as we're moving forward within the realm of psychiatry, science, psychology, all these different realms, and plant medicine and psychedelic research alike, I think that we're really starting to get to a point now where it's not just shooting in the dark or running in the fog, as you said, right? It's actually like, how do we make sure before we administer these to someone that they're actually someone who's going to benefit from them? Because, as I imagine you've been able to tell in some of your research too, some people just do not react well to psychedelics. I've met many people, and that's another one of the main reasons I made the show, is because it takes a lot of discernment for an individual to be able to understand if something like ayahuasca or psilocybin or even ketamine might be able to help them. At least if they're interested in it, then we can run the genetic test. But I think there's many people that might hear it, might think it's cool, but at the same time, they're not really meant to do it. And have you found any people within your research that have been challenged within the experience, not only from the experience, but maybe on a genetic level, like their being is just not set up for success with regards to substances like ketamine, psilocybin, et cetera?
I would say no, actually, because the programs that we are having with the companion diagnostics are just about to start. For our ketamine program, we so far only rely upon a clinical characterization of these individuals as being treatment resistant. But I'm quite certain that with time, we will end up in a situation where we will have to face individuals who are very interested in getting a particular treatment, but where we can say beforehand, look here, it seems as if the likelihood is less than 10% that you will have an adequate response. That doesn't mean that I, as a physician, would necessarily say that therefore you cannot have the medicine, but at least we should arm the patients with these figures so they can make an informed decision.
That makes perfect sense. And, I've actually yet to try ketamine. It's one of the ones that I've just been holding off on. I'm like, I don't know if it feels right, but one of the things that I'm huge on is cannabis, right? Like I mentioned, and I've been hearing a lot of talk recently surrounding combining ketamine and cannabis. Now, I have no idea if you've ever done this before, but I'm ultra curious to see if you have any information on what that interplay might be like, or if you've had that, or if you've seen that experience before. I was recently talking to a buddy of mine, and he was like, hey, when it comes to psilocybin or LSD or even MDMA, he's not a big cannabis person. So he's like, including cannabis can be a really challenging process within those medicines. But he's like, ketamine, on the other hand, I found it almost fits together like perfect puzzle pieces, cannabis and ketamine. And so I'm curious if you've looked into that at all. I have no idea. I didn't read that in your research, but I figured I'd ask you because I'm ultra curious.
Yeah, no, unfortunately, we don't have any data on that so far. I think this is one of the typical things that will emerge over time as medications become available. In psychiatry, for instance, we know that sometimes it makes sense to combine two different antidepressants, and that's typically something that has not always been tested in clinical trials, but has been built on the understanding of clinical practice. I wouldn't exclude that there could be benefits and that there could be synergies, but actually, when you are conducting regulatory clinical trials, often regulators want you to conduct them in as clean a setting as possible. So they actually say that you cannot take other compounds that have a potential to interfere. So we, for that reason, are not able to include patients who are commonly using cannabis, for instance, in our clinical trials. But we know that these people are everywhere and they are out there, and they eventually will be the users of the medication. But that type of information is typically not generated until a medicine has reached the market.
Yeah, it's fascinating. I think there's so many different interplays that could potentially be beneficial within these medicines. Who knows? Really, I think it's a person by person basis as well. Yeah. And, one of the things that I really love thinking about when it comes to the realm of psychedelics, plant medicines, ketamine, all of these different molecules and medicines is the idea that many of them allow you to have a profound experience that really cannot be described by words. But at the same time, I love to dive into how people might describe those experiences. And so with you coming from a psychiatry background and also being into science and all of these things, how would you describe some of the profound experiences that your patients have described, right? When they go through and they come out of this dissociative experience, what are they telling you about the experience? Like, I imagine those things are hard to map out and really create like an objectiveness to, because they're very subjective. But what are some of the things that people have told you once they've come out that they've experienced within this dissociative type experience? Because I know now you're focusing on potentially taking that experience out of it, but I imagine there's been runs that you've had where you've had that a dissociative component to it. So I'm curious what people have told you.
Yeah, I mean, they are using different words when they've had these experiences. I mean, for the traditional psychedelics, it's often, first of all, it's often statements that they cannot talk about because it's special. But some are referring to them in terms of a journey, often comments around vision. Colors become different. The things they see around themselves are changing. For the more dissociative compounds, I think some comments are more about being outside of your body, not really being completely linked to personality and the and body who you normally are. So borders are getting a bit more blurred. But I think the hallmark in a way is that these experiences are so unusual that it's difficult to talk about them. And whether this is because they haven't had these experiences before, or whether it's because they have a quality that doesn't really lend itself to description by language. I don't know that.
I mean, it's fascinating because, I've heard people try to describe these experiences and I've tried to describe mine, but there's a certain point where I think it's beyond language, right? It's beyond words. And, one of the fascinating things is, within the realm of dissociation, one of the ways in which I've had friends and colleagues of mine describe that have used it for depression, specifically ketamine, is that they realized that they actually had the direct experience that they were not their thoughts, right? And we hear this a lot within the realm of psychology and psychiatry that, hey, you're not your thoughts, but it's different to know that and then to have the direct experience of it. And I think for so many people, they describe having this experience where they were outside of their body. They were able to actually view their thoughts rather than identify with them. And in that moment realized, oh, well, if I'm observing my thoughts, then I must not be the thoughts. I must be the thinker behind the thoughts, right? Or the pure awareness behind the thoughts. Yep. And I think that's one of the most fascinating things because I love mystery. I love knowing that I do not know because I'm an eternal investigator. And so when people say things like that, it really adds to that mystery component of it. And I think one of the biggest misnomers within the realm of science and spirituality is that spiritual people say, oh, if there's science behind it, it's not magical. Science people say, oh, if it can't be described, it's not science. I think they're kind of both two sides of the same coin. I think that even though we understand the science behind a light bulb, it doesn't make it any less magical, right? Like it's still an incredible feat of human discovery. And I think that as psychedelics are coming back into the mainstream, I think we're going to see some more of this kind of blending of science and spirituality that actually lends basis back to alchemy, right? Which was the branch of science that really combined those two as two sides of the same coin. And I think that really is powerful. And, I'm curious for you, I imagine people will listen to this that potentially will either be doing ketamine already or be interested in it. Coming from your background, what would be some of the instances that, say, if you were working with someone, things you find that you would say, hey, maybe ketamine is not the right thing for you? Because one of the things that I want to do with this show is not just speak to the incredible benefits within these medicines, but also allow people to have better tools from which to discern in their own life whether or not these things are safe. Because we know that even though these things are incredible and they can be done in a pharmaceutical or hospital setting, most people are, at least in the US, are going to try them without that type of set and setting. And so I'm curious for you, like, what are some of the things you would share that would allow people to go, oh, I might have that actually. Maybe I should wait to do ketamine until I'm in an actual clinical setting.
Yeah, I'm very grateful that you bring this up because it's very important. It's important to find the right patients for a certain treatment, but it's also important to identify the ones who shouldn't have it. And I can look at what patients we typically tend to not include in our program. I think one of the key groups is persons who have a tendency to have psychotic experiences. It could be a psychotic disorder proper, like schizophrenia, for instance, but also people who have had previous experience with psychosis. I mean, some individuals, when they are depressed, get psychotic features, and those. For now, at least, probably should not explore ketamine. We will learn over time if it's a good idea, but psychotic experiences previously should be avoided. I also think that people who have a tendency to increase blood pressure today are to some extent excluded from clinical trials. It is because it's known that when you give ketamine as an anesthetic agent, you see a transient blood pressure increase. We haven't seen it with our formulation for the reasons I gave you in the beginning of the talk. But I think it's always better to start on the safe side, and then with time we will see whether we can give also our prolonged release formulation to individuals who have a clear hypertension. For now, we want to avoid that because safety always comes first.
Yes, absolutely. And speaking of safety, one of the things I've heard about within the realm of ketamine, and again, I've yet to try it, but I've heard that it can be addictive. And I'm curious if you've come across this and if your version of it can mitigate that effect as well. Because again, this isn't exactly my realm. Like I have plenty of friends that have interacted with it, but one of the things that I've heard from people is like, yeah, you can get addicted to it pretty easily. And so I'm curious for you, have you found that? And if so, is it similar to like a tobacco addiction? Is it similar to something that's a little bit less addictive? Like how addictive is it? Like on a scale of 1 to 10, if that makes sense.
Yeah. Yeah, so I think we should be very clear about that there is a potential for addiction with ketamine. History has shown us that there are people who are addicted. But I think we need to be humble here and realize that we need to explore this very carefully. I think if our medication will indeed live up to the vision that we are having to provide antidepressant benefit without causing dissociation, I think patients who are taking this medicine as indicated will have a low propensity to develop addiction because they will not experience the dissociative high. But we should also recognize that there are persons who, for different reasons, want to achieve this. Our plan is to be very diligent in both how we develop the compound. We are going to explore its specific trials. We need to interact carefully with regulators to make sure that we are bringing the compound to the market in a responsible way. And I mean, there's different things you can do about that. That's still up for discussion with regulators. So I will not say that I'm absolutely confident that there is no risk of addiction. I think that the risk is much less than with other ketamine formulations, but we will invest quite a lot of work and effort in trying to really minimize the potential addictive properties of our prolonged release formulation.
Yeah, I've heard of people combining ketamine and oxytocin. Have you heard of that before? And does that potentiate the risk for addiction? I don't know if oxytocin is something that people can become addicted to, but I was curious because I've heard that formulation before, and I'm curious what your experience with that is.
Yeah, I think the risk of addiction to oxytocin is pretty low. And also the clinical benefit of oxytocin administered alone is not tremendously high. I mean, I would be very curious in understanding a bit more about it, what it would look like together with ketamine. It's not something that we currently focus on, but of course we are following the field and are very interested in learning more about the potential for such an interaction.
Yeah, it's really cool. And what it's showing me that I already realized, but I'm continuing to realize deeper and deeper layers, is that the future of mental health is very unique and very bright, is what I feel. And, I know we talked about this a little bit, we covered a little bit, but, I want to ask you just, straight up, what do you think the future of mental health is? If we could have it Hans Eriksson's way, what would the future of mental health be?
First of all, I agree with you. I think that the future is very bright. I think we have for a long time neglected the enormous supply of different molecules that nature has brought to us over millions of years that we now are starting to harvest, like we are doing with let's say, psilocybin. There is, in all likelihood, many more compounds out there. So I think going for the natural pharmacopoeia is one very interesting thing. But I also think that psychiatry in the future will probably be less therapy. It could be from very simplistic, long duration interventions. So I think we will see more of an integration here. But above all, I think that the ability to identify individuals and predict their likelihood of having a good response to an intervention, whether it's a medicine, as in our case, whether it's a therapy, as in some other cases, that's another thing. But making sure that we are giving the right treatment to the right patient.
Yeah, it's so important. I think we both said before, I think this realm is so powerful and it has so much potential. But we need to be able to actually have some foundational aspects that allow us to be able to tell, like, who is going to benefit, who could potentially not benefit from this, and how do we qualify the right people and also disqualify the people that aren't going to potentially benefit from these experiences so that we have more harm reduction. Because I'm huge on harm reduction, especially within the psychedelic space, especially when we're talking about, of course, ketamine gets into this category too, but when we're talking about psilocybin or LSD or something that really like disintegrates you, I think that integration period is often looked at as just like, okay, what do you do from the experience you have? But it's also like, how do you reintegrate into daily life after that experience? And I think a lot of people, when they miss that, they could potentially end up, being a little confused for a while, right? Not knowing how to place what they experienced. And I think that being able to have more of a foundational structure as to how to interact with these medicines with benefits, right, and without risks, I think is huge. And Hans, this has been an amazing conversation, man. I'm really curious where people can go to find out more about brain health, where they can find how to connect with you, anything you have coming up that you'd like to pitch, anything like that. Tell the people where they can find you and connect with you, my man.
Okay, so as a company, we are based in Munich, Germany, but we're also present on the World Wide Web. So we are at www.brain-brainhealth.com.
Perfect. And, I have one last question for you, Hans, and that is this. Let's say someone is extremely inspired with the conversation we just had, and they're looking to be able to discern if psychedelics and plant medicines are right for them in their lives. What is the one piece of advice that Hans Everson would suggest to them to allow them to be able to discern whether or not these medicines are right for them?
I think they should talk to a person who is experienced in this field. It may be a psychiatrist or a clinician, but it may be also someone else who has a solid experience and who can treat these powerful interventions with the responsibility that it takes. Not selling them too hard, but not also being too concerned about potential downsides. There is a broad sweet spot in the middle, which I think could be helpful to lots of people in need.
Yeah, I love that. Okay, guys, when Hans first reached out to me about coming onto the show, I was immediately excited to dive in with him. As I mentioned in the intro, the topics we discussed today are crucial in being able to understand the pharmacology of how these medicines work within the physical, emotional, mental, and spiritual bodies of the human being. And having the opportunity to interview Hans and allow his voice to be heard by more people is truly a gift that I am grateful to be able to share with each of you. For any of you who are looking to dive into Hans's world and stay up to date on all of the amazing things he is up to, make sure to check out the show notes where we will be listing all of the ways you can find him and connect with him. Hans, thank you so much for taking the time to come onto the show and discuss the realm of plant medicines and psychedelics with the listeners and me today, for doing the important work you're doing in the world that is giving more credibility and a deeper understanding to how these medicines can impact quality of life for human beings, and for being a leading voice behind psychedelics and plant medicines as potential medicines. And until next time, my brother, may your journey be smooth and full of light. Aho.